Hello, and welcome to Blue Cross North Carolina's webinar on risk-adjustable behavioral health coding. As we get started, we kindly ask that you disable any AI note-taking tools, as they will be manually removed once the session begins. Today's presentation will be available on the Blue Cross North Carolina Providers Risk Adjustment webpage for educational use. If you have questions, feel free to drop them in the Q&A box, or you can email us at bcbsncriskedj@bcbsnc.com. We'll follow up with responses via email after the webinar. This presentation has been approved by the AAPC for one CEU. Please note, you must attend at least 75% of the presentation in order to be awarded your certificate. Certificates will be emailed within 2 weeks of the presentation, along with the slide deck to the email address used during registration. If you've not received your CEU within 2 weeks, please contact us via email at the address listed on the previous slide, as well as this slide. This presentation is intended for both physician and office staff. The information contained in this presentation and responses to the questions are not intended to serve as official coding or legal advice. All coding should be considered on a case-by-case basis and should be supported by medical necessity and the appropriate documentation reflected within the medical record. Before we begin, I'd like to introduce our risk adjustment provider engagement and education team. Our team is composed of experienced nurses and coders from diverse healthcare backgrounds with over 30+ years of combined experience in risk adjustment, clinical care, and coding. We bring a wealth of knowledge and expertise to our program, ensuring we provide quality risk adjustment education and support. Our mission is to empower providers in risk adjustment coding and improve chronic condition management. Our presenters today are Jacqueline Duncan and Missy Leggett, and I am your host, Trish Burns. Lastly, here's a brief overview of the key objectives we aim to cover in today's webinar. While our intention isn't to turn you into experts in behavioral health and substance use disorder coding, we do hope you leave today with greater confidence and a clearer path to success within coding these types of visits. With that, I'll hand it over to Jackie to get us started. Good afternoon, Jackie.
Good afternoon, Trish. Thank you. Hello, everyone. Let's get started today with substance use, abuse, dependence, and remission. It is important to understand the different levels of substance use for accurate diagnosis and effective treatment planning. Understanding levels of substance use for the accurate diagnosis and treatment includes: for substance use, refers to the casual or social consumption of alcohol, drugs, or chemicals. It typically doesn't interfere with responsibilities or relationships. Use is moderate and controlled without significant negative consequences. For substance abuse, it involves harmful patterns of use and use that may cause distress or impairment. Signs include repeated failure to meet obligations, use in dangerous situations, legal issues, continued use despite social or interpersonal problems. In substance dependence, a more severe condition marked by physical and psychological reliance, key indicators include tolerance and withdrawal, using more than intended, failed attempts to cut down, neglecting important activities, and continued use despite health issues. Substance abuse includes various categories, each with a unique risk and characteristic. Alcohol dependence involves a strong craving and difficulty controlling intake, leading to serious health problems like liver disease, such as liver disease. Opioids, including prescription painkillers and heroin, have a high potential for misuse and overdose, contributing to the opioid crisis. Tobacco use, primarily through cigarettes, is a leading cause of preventable death due to risks like lung cancer and heart disease. Cannabis, used both recreationally and medicinally, can lead to dependence and cognitive issues. Sedatives and hypnotics, such as benzodiazepines, are highly addictive and can cause severe withdrawal symptoms. Cocaine, an illegal stimulant, poses a serious health risk, including heart attacks and mental health problems. Caffeine, commonly found in beverages like coffee and energy drinks, can cause dependence and anxiety when consumed excessively. Hallucinogens such as LSD alter perception and mood, potentially leading to psychological distress and accidents. Lastly, volatile solvents, often inhaled from household products, can cause significant damage to the brain, liver, and kidneys, and these sometimes result in sudden death. Now, let's take a deeper dive into alcohol use disorders. These are medical conditions that are diagnosed when a person's drinking of alcohol causes major concerns or harm and a decrease in the ability to function. Alcohol use disorder can be classified as mild, moderate, or severe. Risk factors for developing alcohol use disorder are family history, depression, and other mental health problems, as well as a history of trauma. The reason these last two risks are important in the possible development of alcohol use disorder is that people sometimes use alcohol to self-medicate their depression or trauma. Alcohol can seem like it is working to make people feel better, but it does not continue to work in the treatment of these other disorders. The symptoms of alcohol abuse are things like not being able to stop drinking once it has started, feeling irritable or upset when unable to drink alcohol, frequent hangovers, problems at work or school, and problems with relationships and problems with law enforcement. In addition to these kinds of issues, alcohol over time can cause medical issues. So, what are some health risks and treatment approaches for alcohol use disorder? Health risks may include chronic alcohol use, which can lead to serious health issues like liver, stomach, and pancreatic diseases, heart arrhythmias, diabetes complications, and increased cancer risks. Treatment approaches are not a one size fit all and may be outpatient or inpatient, provided by specialists, therapists, or healthcare providers. The three main categories are medications, behavioral treatments, and mutual support groups. For medications, non addictive options that may help reduce or stop drinking and prevent relapse. This can be used alone or with other treatments. For behavioral treatments, also known as alcohol counseling or talk therapy, these can be provided by licensed therapists to help change drinking behavior. And then groups like Alcoholics Anonymous offer peer support to reduce or stop drinking. It is important to note that people with severe alcohol use disorder may need medical supervision to safely manage alcohol withdrawal, which can be life threatening. Doctors can prescribe medications to ease symptoms and to ensure safety. Now that we have explored some terms and the substances that are used, let's look at the definition of remission. Remission is important in coding because it has a specific criteria and it must be documented by the provider. Full remission occurs when 2 months have elapsed, either without the patient experiencing significant symptoms or without the patient meeting the DSM-5 criteria for the disorder. The DSM-5 is the standard classification of mental disorders used by mental health professionals. Partial remission entails either no experience of significant symptoms or the patient's symptoms to meet the DSM-5 criteria for the disorder within a 2-month period of time. However, clinical determinations of full And partial remission, again, should be left up to the provider. Remember, remission determination requires the clinical judgment and documentation in the words of in remission. When coding diagnoses related to substance use, remember to look for and encourage your providers to document specifically. Is there abuse or dependence present? Is it current or recurrent? If in remission, is it partial or full? What is the severity of the condition? Is it mild, moderate, or severe? Are there current symptoms such as intoxication, withdrawal, or psychosis? And how many substances are involved? Make sure each substance is addressed independently and documented as described above. Keep in mind that when the provider documentation refers to use, abuse, and dependence of the same substance, as in alcohol, opioid, cannabis, etc., only one code should be assigned to identify the pattern of use based on the following hierarchy. If both use and abuse are documented, assign only the code for abuse. If both abuse and dependence are documented, assign only the code for dependence. If use, abuse, and dependence are all documented, assign only the code for dependence. If both use and dependence are documented, assign only the code for dependence. Now let's review a couple of scenarios regarding use, abuse, and dependence. Patient presents with alcohol use, and this code is F10.90. This code is used for general alcohol use that is unspecified and uncomplicated. It applies when a patient consumes alcohol but does not meet the criteria for abuse or dependence. For the second scenario, this patient presents with alcohol use and abuse. You would code F10.10. This one is for alcohol abuse without dependence. This one is used when the patient shows harmful drinking patterns, causing significant impairment or distress, but has not developed dependence. Next, we have the patient with alcohol abuse and dependence. This code is F10.20. This code indicates alcohol dependence, uncomplicated, and is used when the patient has developed dependence on alcohol, which can include tolerance, withdrawal symptoms, and a very strong desire to drink. Next, we have a patient with alcohol use, abuse, and dependence. For this, we code F10.20. This code is again for the alcohol dependence uncomplicated, which applies when the patient meets the criteria for use, abuse, and dependence without complications. And for the last scenario, the patient presents with alcohol abuse and dependence in remission. For this, we code F10.21. This code is for when a patient who is previously diagnosed with alcohol abuse or dependence has stopped drinking recently or for a long period. It means they are in remission. Some alcoholic description codes. So the word alcoholic in the code description, it does not mean dependence. In order to use code F10.20, alcohol dependence, the provider needs to document dependence, dependent, or alcoholism. When a condition with a descriptor of alcoholic or when the condition is due to alcohol use, code first the code for the alcoholic condition and then the pattern of the alcohol use. When dependence or abuse is not known, assign code F10.988. Alcohol use unspecified with other alcohol-induced disorder. Dependence coding guidelines. The provider needs to state the patient has an addiction or has a dependence. In general, long-term or chronic use of a medication or drug should not be considered dependence if used for medical purposes unless the provider documents dependence, addiction, or withdrawal. Now let's talk about medical conditions due to substance use. These medical conditions due to substance use, abuse, and dependence are not classified as substance-induced disorders. They are coded separately. Assign the diagnosis code for the medical condition as directed by the alphabetical index along with the appropriate psychoactive substance use, abuse, or dependence code. For example, for alcoholic pancreatitis due to alcoholic dependence, we would assign an appropriate code from the subcategory K85.2. And in this case, it would be K85.20, alcoholic-induced acute pancreatitis without necrosis or infection, and the appropriate code from subcategory F10.2, such as F10.20, which is alcohol dependence uncomplicated. It would not be appropriate to assign code F10.288, alcohol dependence with other alcohol-induced disorder, when alcohol-induced condition, like pancreatitis, has its own specific code in another chapter of ICD-10. Now let's talk about mental disorders due to substance use. These are also coded differently. Substance and medication-induced mental disorders refer to depressive, anxiety, psychotic, or manic symptoms that occur as a psychological sequence of the use of substances of abuse or medications. It may occur during active use, intoxication, or withdrawal. These mental disorders that are caused by the substance are coded within the substance categories. For example, a patient presents with cannabis dependence, with cannabis-induced anxiety disorder. There is one code for this, F12.280. So let's review some documentation and coding tips for substance use. It is important to specify the substance and the severity of the disorder. This helps to ensure accurate coding and reflects the full complexity of the patient's condition. For example, opioid dependence is coded differently from opioid abuse, and each has its own ICD-10 code. For patients in remission, make sure to clearly document whether they're in early or sustained remission. This information has a direct impact on risk adjustment, so using the correct ICD-10 codes like F11.21 for opioid dependence in remission is necessary. And do not forget, have your providers document any complications or coexisting mental health conditions. If a patient has alcoholic liver disease or an anxiety disorder related to substance use, those should also be captured with additional codes, which impacts the overall risk score. Now let's try a coding scenario. In this scenario, the provider documented in the assessment, patient is alcohol dependent in remission for 8 years. The provider's plan for the patient. The patient is encouraged to continue abstinence and continue attending their AA meetings. So what code would we assign here? For this scenario, we would assign code F10.21, alcohol dependence in remission. Full remission occurs when 2 months have elapsed, either without the patient experiencing any significant symptoms or without the patient meeting the DSM-5 criteria for the disorder. Remember, in remission requires the provider's clinical judgment and documentation. We as coders cannot assume that they are in remission. This must be documented. Now let's discuss some mood disorders. As you can see, these are categories from F30 through F39, and we will be touching on each of these. Let's start with F32 for depression. In order to screen for depression, A provider may ask people to fill out a standardized questionnaire to help identify the depression and determine how severe it is, but questionnaires cannot be used alone to diagnose depression. Providers use specific lists of symptoms or criteria to diagnose the different types of depressive disorders. To help distinguish depression from ordinary changes in mood, providers determine whether the symptoms are causing significant distress or are impairing the person's ability to function. A previous history of depression or a family history of depression helps support this diagnosis. So let's take a look at some of these tools. So the PHQ-2 is a quick self-administered screening tool for depression, derived from the longer screening tool PHQ-9. This is used as a first step. Any positive results would be followed by the PHQ-9 questionnaire. So the PHQ-9 assesses depression and related mental health concerns such as anxiety, panic disorder, or sleep issues. And this also helps to guide the diagnosis and treatment planning. The Hamilton Depression Rating Scale, or the HAM-D, is a clinician-administered tool, and it has 17 items that will evaluate depression symptoms over the past week. This is most widely used in the clinical setting. The Beck Depression Inventory, or the BDI, has 21 items of self-report on the questionnaire. It measures attitudes and symptoms of depression. It is available in paper forms and digital formats, and it requires a 5th to 6th grade reading level for the patient, and it takes at least 10 minutes to complete. Some diagnosis considerations for the clinician. Doctors use symptoms criteria to distinguish depression from normal mood changes. Diagnoses depend on symptom severity, functional impairment, and distress. Family or personal history of depression will also support the diagnoses. Once the depression has been diagnosed, it must be treated. Treatment depends on the severity and type of depression. For mild depression, it may include support, including doctor's visits and education, and psychotherapy. For moderate to severe depression, this may include drugs, psychotherapy, or both, and sometimes electroconvulsive therapy known as ECT. Seasonal affective disorder or seasonal depression occurs at the change of seasons when daylight hours decrease. Phototherapy, which uses special lamps that mimic daylight, can be very helpful. Prolonged grief disorder, a psychotherapy tailored to this type of disorder is recommended. Major depressive disorder is a severe form of depression where, in addition to a depressed mood and loss of interest in doing any activity, the patient also experiences changes in weight and appetite, too much or too little sleep, slow motor function, loss of energy, indecisiveness, and feelings of worthlessness that may be accompanied by suicidal thoughts. When coding major depressive disorder, it is critical to capture the episode, meaning whether it is single or recurring, and then capture the severity as well, and if there is any kind of remission documented. Specificity is key in forming an accurate picture of what is happening with the patient. The unspecified code on the right side of the slide, F32.9 and F32.A, should rarely be used and only when nothing else, such as the severity or episode, is known about the disorder. Now let's drill down a bit further with the severity of the condition. So once we've decided whether or not the documentation supports F32 for a single episode or F33 for a recurrent, then we need to decide on the severity. All of this is always based on the documentation of the provider. Categories F32 and F33 are further subdivided into third characters, and sometimes fourth characters to provide information about the current severity of the disorder. So on the slide, let's take F32, and that is major depressive disorder, single episode, mild. Apply that same nomenclature to the rest of the severity categories. 1 is moderate, 2 is severe without psychotic features, 3 is severe with psychotic features, 4 partial remission, 5 full remission, 8 other depressive disorders, and 9 unspecified. And here is an important note. Third characters 0 through 5 are assigned only when the provider documentation of severity is included in the medical record. Remember, accurate and specific documentation not only helps with coding, but also contributes to better patient management and care continuity. So let's make it a practice to capture the severity level comprehensively. Let's now move on to bipolar disorder, also known as manic depression, and the F31 category. People who have this serious illness go through unusual mood changes. They go from very happy or up and very active to very sad and hopeless or down and inactive, and then back again. They often have normal moods in between. The up feeling is called mania. The down feeling is called depression. Treatment consists of different classes of medications used alone or in combination, such as mood stabilizers, antipsychotics, antidepressants, and anti-anxiety drugs. There are 2 types of bipolar 1 and bipolar 2. The main difference between bipolar 1 and bipolar 2 disorders lies in the severity of the manic episodes caused by each type. A person with bipolar 1 will experience a full manic episode, while a person with bipolar 2 will experience only a hypomanic episode, or a period that's less severe than the full manic episode. As with all mood disorder codes, it is important for your provider to document the correct category, whether it is bipolar 1 or bipolar 2, with or without psychotic features, with the severity or remission status. If none of that information is documented and you only have a diagnosis of bipolar, use F31.9, which is bipolar disorder unspecified, and then have a discussion with your provider. Let's now take a look at this series of codes. These include manic episodes or mania. There is a reminder in the slide of the F codes we've discussed this morning. The F30 codes require 4th and 5th digits to identify the severity of the current episode and whether or not psychotic symptoms are involved. Manic episode may be elevated, expansive, or irritable in nature. Manic episode mood changes typically last for a week, at least a week. If less than a week, they are severe enough to require hospitalization. F30 codes are used to identify a single episode of mania. Select the appropriate 4th and 5th digit codes to identify the severity of the current episode to indicate whether psychotic symptoms are involved. For instance, documentation of someone with a mild manic episode without psychotic symptoms would be coded as F30.11. The 4th digit indicates without psychotic symptoms, and the 5th digit indicates the mild severity. In the second row, F31, these codes are all bipolar codes. And as we've just discussed, these codes describe the serious mental illness with severe mood swings, both manic and depressive. F34 codes describe persistent mood disorders. This category is used to classify conditions whose primary feature is a disturbance in mood, but whose symptoms do not meet the severity of those categorized to major depressive, manic, or bipolar disorders. And the F39 codes are unspecified mood affective disorders. So here are some tips for documenting and coding mood disorders. Be specific about the type of disorder. Whether it is depression or bipolar, each needs its own ICD-10 code. For example, major depressive disorder is coded differently from bipolar disorder, so capturing the right condition is necessary. It is also helpful to include the severity of the disorder, whether the patient is experiencing an acute or chronic episode. For instance, severe recurrent major depressive disorder, F33.2, is coded differently from mild single episode, F32.0. If the patient has psychotic features or if the mood disorder is in partial or full remission, these should be documented as well, as they influence the final coding. This level of detail ensures a complete picture of the patient's mental health and appropriate coding. Now let's look at another scenario. This one is for mood disorders. This is a coding clinic that actually came out in 2020 in the first quarter from page 23. Mr. Bell was diagnosed with bipolar disorder and a major depressive disorder, recurrent mild. What code is assigned when both conditions are documented? So the tips for this scenario are category F31, bipolar disease, has an excludes one note for major depressive disorder, recurrent. And then category F33, major depressive disorder, recurrent, has an excludes note for bipolar disorder, F31. So let's take a look at how we would code this scenario. For this scenario, you would code F31 bipolar disorder unspecified. And it is important to remember that bipolar disorder includes episodes for both depression and mania. In this case, there was no additional documentation provided regarding the type, severity, or psychosis status of the bipolar disorder. So since this specific information was not available, we use the unspecified code, F31.9, for bipolar disorder. Now I will hand it over to my colleague, Missy, to discuss dementia. Your turn, Missy.
Thank you, Jackie. Good afternoon, everyone. Let's jump right in and talk about dementia. What is dementia? Chances are you have known someone that has been impacted by some form of dementia. Some of us may have even experienced firsthand the caregiving responsibilities associated with the group of conditions. Let's start by clarifying that dementia is not a specific disease. Dementia is a group of conditions or symptoms that are characterized by impairment of at least two brain functions, such as memory loss and judgment. Symptoms include forgetfulness, limited social skills, and thinking abilities so impaired that it interferes with daily functioning. Dementia is a syndrome in which there is deterioration in cognitive function beyond what might be expected from the usual consequences of biological aging. A common progressive manifestation associated with this disease is behavior changes. Some of these may include aggressive behavior, becoming less active, impulsive or disinhibited behavior, and emotional outbursts. Previously, in V24 CMS HCC model, dementia was classified as HCC 51, dementia without complications, and HCC 52 with complications. Now, in V28, there are three HCCs for dementia based on severity. HCC 125 is for severe, 126 for moderate, and 127 for mild or unspecified. Each of the new dementia HCCs have a RAF score of 0.341. Let's review the stages of dementia. In the early stage or mild stage, they may show no symptoms or only mild changes. They are still independent but may forget recent events or repeat themselves, and their care needs include support with planning and organization, encouragement to maintain independence, and monitor for changes in memory or behavior. In the middle or moderate stage, this is the longest stage and is noticeable memory and planning issues. They may forget names, get confused about time, and their care needs include assistance with daily tasks, safety supervision, examples are wandering or confusion, and structured routines and reminders. In the late or severe stage, they need full assistance with basic functions. They may forget close family, experience emotional changes, and their care needs will be help with basic activities such as eating, toileting, or hygiene, full-time care or supervision, and management of emotional or behavioral changes. And lastly, in the final stage, loss of speech, mobility, and independence, and most likely bedridden. Care needs include total care of mobility, feeding, and hygiene. Palliative or hospice care may be appropriate, and the focus is on comfort, dignity, and quality of life. Now we will review the different types of dementia. The most common form of dementia among older people is Alzheimer's disease. With this disease, brain neurons stop functioning, lose connections with other neurons, and die. Alzheimer's disease onset is generally over the age of 65 and is the leading cause of up to 70% of dementia cases. According to the CDC, minorities and women are more likely to develop Alzheimer's disease. Symptoms may include increased need for assistance with activities of daily living, including dressing, eating, and bathing. Individuals may have trouble remembering recent events, the names of people that they know, and eventually may not recognize their own family members. Ultimately, total care will be necessary for these patients. Currently, there is no cure for Alzheimer's disease, and symptoms can be managed with a variety of approaches, which we will discuss later in the presentation. One cause that is specific to Alzheimer's is the buildup of the beta amyloid protein. Abnormal levels of this naturally occurring protein clump together to form amyloid plaques. These collect between the neurons and disrupt cell function, resulting in the symptoms related to Alzheimer's disease. As the neurons are injured and die throughout the brain, connections between networks of neurons may break down, and many brain regions begin to shrink. By the final stages of Alzheimer's, this process, called brain atrophy, is widespread, causing significant loss of brain volume. Other contributors to Alzheimer's disease symptoms include neurofibrillary tangles and chronic inflammation. The G30 category is used to code Alzheimer's dementia. As always, it is important to code to the highest specificity known. Conditions such as behavioral disturbances, anxiety, and psychosis should also be captured and coded using codes from the F05 and F02 code sets. Another neurodegenerative disorder is Lewy body dementia. In this form of dementia, abnormal deposits of a protein called alpha-synuclein affect chemicals in the brain whose changes in turn can lead to problems with thinking, movement, behavior, and mood. Symptom development and change varies greatly from person to person. The disease lasts an average of 5 to 8 years from the time of diagnosis to death. To code Lewy body dementia, you will use ICD-10 code G31.83. You will also use a code from F06.7 to describe any mild cognitive disorder or impairment caused by the underlying Lewy body diagnosis. These conditions will reflect an impairment in memory or thinking that is beyond what is considered normal for age-related symptoms. Vascular dementia describes problems with reasoning, planning, judgment, memory, and other thought processes caused by brain damage from impaired blood flow to the brain. This can develop after a stroke blocks an artery in your brain, and it can also develop from other conditions that damage blood vessels and reduce circulation. A few examples of these include smoking, diabetes, and chronic alcohol use. Vascular dementia symptoms vary depending on the part of your brain where blood flow is impaired. Symptoms often overlap with those other types of dementia, especially Alzheimer's. And symptoms include slowed speed of thinking, delusions, and short-term memory loss. When coding vascular dementia, you will choose from the F01 code set. Providers should be encouraged to include the severity of the condition in their documentation, and you will also have the provider identify and document the underlying physiological condition that has caused the interruption of the blood flow, such as a stroke or chronic alcohol use. Next, we have the frontotemporal disorders, sometimes called frontotemporal dementia. These are the result of damage to neurons in the frontal and temporal lobes of the brain. A variety of symptoms can result depending on the location of the neuron damage. Frontal lobe symptoms include behavioral symptoms such as impaired judgment, difficulty controlling emotions, depression, and falling. When the temporal lobe is affected, symptoms may present as difficulty understanding spoken words, difficulty with identification of objects, and difficulty learning and retaining new information. You will use a code from the G31 code set to communicate diagnoses from the dementia category. You will also include additional codes from the F02 code set to reflect any behavioral disturbances, anxiety, or psychosis. Diagnosing dementia has three parts. Part one is a cognitive test. This will include questions to the patient to evaluate for short-term memory loss. During the assessment, eye movement, speech, and sensation are also measured. Other assessments include a depression screen and mood assessment. Since different areas of the brain can be affected, it is important to include a variety of assessments to note changes within each of the different areas that the brain services. Another piece to obtaining a dementia diagnosis includes a variety of brain scans. A CT scan can be used to identify areas in the brain which may show shrinkage, which is a sign of neuron damage or death, signs of a stroke, whether new or old, a brain tumor, and other abnormalities. An MRI will provide detailed images of the body, including tissues, organs, bones, and nerves. An MRI can also show if the patient has high levels of beta amyloid protein, the proteins that help make up the plaques found in Alzheimer's patients. And finally, a PET scan can be used to diagnose dementia by measuring the concentration of glucose in the brain to reveal how the brain is utilizing energy, or it can be used to measure the buildup of the abnormal amyloid protein in the brain. Lastly, there are a few additional tests available to assist with diagnosing dementia. Genetic testing can be used to look for genetic variations that affect someone's risk of developing dementia. Cerebrospinal fluid testing can be performed to measure the levels of some proteins or other substances that may indicate the presence of dementia. And also blood tests to measure levels of the beta amyloid protein. These additional tests should not be used independently to diagnose dementia, but be used to supplement other testing as directed by the provider. Now that we've discussed the different types of dementia and how to diagnose them, let's talk about the various treatments available and a few tips for caregivers. There is a variety of medications available to treat dementia. The stage and severity of the patient's dementia should be considered when choosing a medication. Some medications, such as Aduhelm, reduce the buildup of the amyloid beta protein found in Alzheimer's patients to slow the progression of the disease, while others, such as Namenda, blocks certain substances in the brain that are linked to symptoms of Alzheimer's disease, therefore reducing the symptoms presented. Symptoms can be managed across all types of dementia using a variety of medications, and the medications may be prescribed to manage sleep disturbances, anxiety or agitation, and hallucinations. Be sure to include the symptoms experienced within your dementia diagnosis coding as appropriate. Here are some coding tips and documentation for dementia. Make sure to specify the type of the dementia, whether it's Alzheimer's, vascular dementia, or Lewy body dementia. This specificity ensures accurate coding. Behavioral disturbances like agitation or psychosis need to be clearly documented. For example, vascular dementia with behavioral disturbances uses a different code than that without behavioral disturbances. Additionally, don't forget to include the severity or the stage of the dementia, whether it's early or late onset. This helps in coding for the appropriate level of care that the patient requires. Lastly, if the dementia affects the patient's ability to perform daily tasks, it's helpful to document that impact as well for accurate coding. Let's take a look at the AHA coding clinic from Q3 2025 related to dementia with behavioral disturbances. The question posed was, a patient had a final diagnosis of moderate dementia with disturbance of behavior and psychotic disorder. Are these conditions coded separately? The answer was to assign code F03.82 for unspecified dementia moderate with psychotic disturbance and code R44.3 for hallucinations unspecified for moderate dementia with disturbance of behavior and psychotic disorder with hallucinations. ICD-10-CM assumes a link between dementia and psychotic disturbances, and in this case, the provider has documented that the patient has a psychotic disorder due to a known psychological condition, which is the dementia. Here's a coding scenario. A patient with known severe dementia due to late onset of Alzheimer's disease is admitted from a senior living facility due to increased agitation and combativeness over the past 3 days. What would be the appropriate code assignment for severe dementia in a patient with agitation and combativeness? You would assign codes G30.1, Alzheimer's disease with late onset, and F02.C11, dementia and other diseases classified elsewhere severe with agitation. Now let's turn our attention to personality disorders. Personality disorders are a group of mental health conditions characterized by persistent and enduring patterns of behavior, cognition, and inner experience. These patterns significantly deviate from what is expected with an individual's culture. Key characteristics of personality disorders include their pervasive and inflexible nature, meaning that these patterns are consistent across many different situations and are difficult to change. They typically begin in adolescence or early adulthood and remain stable over time. Personality disorders are mental health conditions that significantly affect the way a person thinks, feels, and behaves. They can make it challenging for someone to maintain relationships, hold down a job, or even manage day-to-day activities. Personality disorders are generally grouped into 3 clusters based on their characteristics. First, we have cluster A, which includes disorders that are often seen as odd or eccentric. Examples are paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. People with these disorders might be seen as distant or distrustful. Next is cluster B, which includes dramatic, emotional, or erratic disorders. Examples are antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. People with these disorders tend to have intense emotional reactions, difficulty maintaining relationships, and may act impulsively or seek excessive attention. Lastly, in cluster C, which includes anxious or fearful disorders, examples are avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Individuals with these disorders may struggle with chronic fear or anxiety, avoiding social situations, or displaying perfectionistic tendencies. The treatment approaches for personality disorders include psychotherapy as a primary method, which includes cognitive behavioral therapy, CBT, which changes negative thoughts and behaviors, dialectical behavior therapy, DBT, helps with emotional regulation and relationships, especially effective for borderline personality disorder, and psychodynamic therapy, which explores past experiences to influence current behavior. Medications may also support treatment, antidepressants for depression and anxiety. There's mood stabilizers to help manage mood swings and impulsivity, and antipsychotics that are used for severe symptoms like paranoia or psychosis. Self-management tips include consistent therapy, having regular sessions that are key to your long-term progress, support systems, strong relationships that provide emotional stability, self-care, including exercise, hobbies, and healthy routines that help support well-being, mindfulness are techniques like meditation and yoga that help manage stress. In education, learning about the disorder helps improve the self-awareness and coping. Combining professional treatment with self-care strategies can significantly improve quality of life and mental health outcomes. Here's another scenario. A patient with longstanding diagnosis of avoidant personality disorder is presenting with increasing social withdrawal and refusal to attend work or social gatherings for the past month due to fear of criticism and rejection. What is the appropriate code assignment for avoidant personality disorder? You would assign code F60.6, avoidant personality disorder. Now let's take a few moments to look at schizophrenia. Schizophrenia is a chronic and severe mental health disorder that affects how a person thinks, feels, and behaves. It's marked by symptoms such as delusions, hallucinations, and disorganized speech. Schizophrenia affects about 1% of the population globally and has a profound impact on an individual's daily functioning and overall quality of life. Schizophrenia symptoms are typically categorized into positive, negative, and cognitive symptoms. Positive symptoms include delusions, hallucinations, and disorganized thinking. Negative symptoms are characterized by a lack of motivation, diminished emotional expression, and poor social functioning. Cognitive symptoms affect memory, attention, and executive functions. Diagnosing schizophrenia requires a thorough assessment based on DSM-5 criteria. The symptoms must persist for at least 6 months, with at least 1 month of active phase symptoms such as delusions or hallucinations. Clinicians use a combination of clinical interviews, standardized questionnaires, and a detailed medical history to make an accurate diagnosis. Treating schizophrenia effectively requires a comprehensive and an individualized approach. Let's discuss the primary components of treatment. Antipsychotic medications are the cornerstone of schizophrenia treatment. They help manage symptoms by affecting neurotransmitter activity in the brain. Typical antipsychotics are first-generation medications like haloperidol and chlorpromazine are effective but may have more side effects. Atypical antipsychotics are second-generation medications such as risperidone and olanzapine generally have a better side effect profile and they are often preferred. Psychotherapy alongside the medication is crucial. We have the cognitive behavioral therapy, CBT, which we talked about earlier, which helps patients identify and change negative thought patterns and behaviors, reducing the symptoms like delusions and hallucinations, and family therapy, which educates family members about the disorder and improves family dynamics and support. Supportive treatments address the broader impacts on a patient's life. There's rehabilitation programs that develop skills needed for daily living, such as managing finances and personal care, vocational training, which assists in gaining employment skills, improving quality of life. Lifestyle and self-care is vital for overall well-being. With regular exercise, the physical activity helps reduce symptoms and improve mood. Healthy diet supports both physical and mental health. Using these treatments can significantly improve outcomes and quality of life for patients with schizophrenia. When documenting schizophrenia, it's important to specify the exact type, such as paranoid or catatonic schizophrenia. In addition to the type, documenting psychotic symptoms like delusions or hallucinations gives more depth to the record. For example, schizophreniform disorder has its own code, F20.81, so be sure to document and capture the details. Make sure to also document the phase of schizophrenia, whether the patient is in an acute phase, a chronic state, or remission, including coexisting conditions such as depression or substance use is also necessary for an accurate awareness of the patient's health. Lastly, describe how schizophrenia affects the patient's daily life, including their ability to work, maintain relationships, or take care of themselves. This detail can influence treatment planning and more accurate coding. Here's our last coding scenario for today. A 28-year-old male presents to the clinic with a history of paranoid thoughts and auditory hallucinations. The patient reports hearing voices telling him that people are watching and plotting against him. These symptoms have worsened over the past 6 months, and he has begun avoiding social interactions, fearing harm to others. There is no history of substance abuse, and his mental health history includes similar episodes of paranoia and delusions in the past. The assessment includes schizophrenia, paranoid type, characterized by auditory hallucinations and paranoid delusions. The plan is to start risperidone 1 milligram daily, schedule a follow-up in 2 weeks to assess response to medication, and refer to a psychologist for cognitive behavioral therapy. What would be the appropriate code assignment? You would assign code F20.0, paranoid schizophrenia. As we wrap up our presentation today, we want to leave you with a few coding tips for behavioral health. When documenting behavioral disorders, your provider should be encouraged to document to the highest specificity known. The type of a condition, the frequency of the episodes, the current status of the condition, and the severity of the condition should all be assessed and documented so that it can be reflected in the coding for each patient. Also, specific to dementia patients, you should include code Z91.83 to reflect wandering and dementia when present. I'll now turn it back over to our host, Trish. Thank you, Trish.
Thank you, Missy. Thank you for joining our educational webinar today. We appreciate your time and hope you found the session informative. We offer risk coding training for your practice tailored to your needs and can provide virtual sessions or on-site training. Please use the QR code provided to give your feedback on today's presentation. Additionally, if you're interested in group training, scan the QR code to show your interest. A big thank you to our speakers, Jackie and Missy, for their insightful contributions today. We look forward to seeing you next month for our webinar entitled Frequently Miscoded Risk Adjustable Conditions. For more information about upcoming webinars or group training sessions, please visit our external site using the provided links on the slide. This concludes our webinar. Thank you again and have a wonderful day.